Good afternoon, all. First of all, I would like to thank everybody for giving me this opportunity. So I would like to talk about percutaneous interventions in univentricular hearts. It's a single tertiary care center experience. So patients with single ventricle physiology pose a wide variety of therapeutic challenges. Proper functioning of the total cavopulmonary circuit requires favorable anatomic, physiologic, and hemodynamic factors. This can frequently achieved only by percutaneous or surgical procedures. These days, you have seen increased survival of patients with Fontan circulation. So percutaneous techniques have emerged for new indications or to solve complications which aim to keep this fragile physiology in optimal circumstances. So this study aims to describe the experience in percutaneous interventions done in single ventricle physiology and to analyze the short-term clinical outcomes. It's a single center study, a retrospective study done from May 2017 to May 2022. All patients who have their Fontan circulation completed during this time period were included in the study, and patients who were awaited for Fontan surgery or with biventricular repair wherever it was possible, those patients were excluded from the study. So the variables were collected retrospectively from the medical records. In addition to the demographic data, information on the type of congenital heart defect, the date of Glenn surgery and Fontan, date of each interventional catheterization, and type of procedure performed were obtained. The last date of follow-up of each patient and the overall clinical status were recorded. The analysis was done in 3 different time frames: before Glenn, between Glenn and Fontan, and after Fontan. Procedural and short-term outcome of interventions, as well as the clinical situation at last follow-up, were evaluated. So there were a total of 61 patients who underwent Fontan circulation completion during this time period. Of them, 27, almost 45% patients required percutaneous interventions. The most common heart disease that required interventions was pulmonary atresia intact IVS. The most frequent procedure done in the pre-Glenn period was PDA stenting. In the post-Glenn period, between Glenn and Fontan, the most frequent procedure was collateral closure, followed by pulmonary artery forward flow device closure in 2 patients. After Fontan completion, the procedure that was done was fenestration device closure in view of desaturations. The overall success rate of all the procedures was 100% with no procedural mortality. On follow-up, the benefit was sustained in all. So this was the data of pre-Glenn procedure. This was PDA stenting, and most common heart defect that required PDA stent was pulmonary atresia intact IVS. Some other heart defects that required PDA stent was tricuspid atresia, type 1B, LTGA VSD with pulmonary atresia, and the mean age of the patients was around 1.5 months with mean weight of around 2.3 kgs. The most commonly used stent was Zanz Expedition balloon mounted stent, and the outcome was successful in all with no peri-procedural mortality or morbidity, and the average hospital stay was around 3 days. These were the procedures between Glenn and Fontan, where collateral closure was the commonest and MAPCA closure was the commonest among them. Then around 4 years of age with around average weight of 13 kgs. And most of them were closed with embolization coils. In a few cases, PVA particles were used. And in a single case, both had to be used to close the collateral. And venovenous collaterals were closed using Amplatzer vascular plug. And other procedures were forward flow occlusion of the pulmonary artery, which was done using PDA, lactic PDA occluder devices. Here again, there was no peri-procedural complications, and the average hospital stay was around 3 days. This was post-Fontan patients who required percutaneous interventions. There were 3 patients where fenestration closure was required in view of desaturations. So the fenestration was closed using ASD occluder in 1 and PDA devices in the rest of the 2 patients. So coming to first pre-Glenn procedure, this is a 2 months female child with pulmonary atresia intact IVS with PDA supplying the branch pulmonary arteries. Here, 4 into 15 mm Zane's Expedition balloon mounted stent was used, and this is the post-procedure X-rays showing the PDA stent, and post-stenting saturations improved from 60% to 94% in room air. This is again 2 months child with dextrocardia and CCTGA with pulmonary atresia, where PDA was supplying the branch pulmonary arteries, and 3.5 into 15 mm Zane's Expedition balloon mounted stent was used, and post-stenting saturations improved from 59% to 84% in room air. Procedure was uneventful in all the PDA stents. This is a 4 years child, status post BT shunt followed by right Glenn for common AV canal, unbalanced ventricles, DORV with almost near atresia, near pulmonary atresia. There was a MAPCA arising at T4 to T5 level, supplying the left lung, which measured around 2.8 mm in size and was tortuous. It was closed using Cook coils, embolization coils. In the same patient, there was a veno-venous collateral from left innominate vein to the coronary sinus, which was occluded using Amplatzer vascular plug of 12 mm. This was other patient where 5 years old female child with status post right Glenn for tricuspid atresia, DORV with unrestricted VSD, pulmonary where there was a forward flow from the pulmonary artery after Glenn. So here pulmonary valve was crossed from the venous side through IJV axis, and 8/6 mm LifeTech PDA occluder was deployed at the level of PA band, and this is the post device angio which showed no forward flow across the pulmonary valve. This is a 13 years child, status post right Glenn for mitral atresia, DORV and large unrestricted VSD with PS, as the pressure study showed high Glenn pressures of 17 mm of Hg, pulmonary, and there was a forward flow across the pulmonary valve. So pulmonary valve was crossed from the venous side through IJV, and first that Taishak balloon was placed across and inflated, and we checked the Glenn pressures, which came down to 12 mm of Hg without fall in any cardiac output or systemic pressures. So pulmonary valve was crossed from the venous side, and it was closed using PDA device. This is 25-year male child. Here the procedure is again post-Fontan. So there was a fenestrated Fontan for heterotaxis syndrome, common AV canal with unbalanced ventricles. So TCPC circuit angiogram showed 5 mm fenestration shunting from TCPC circuit to right atrium. So balloon occlusion was done with 12 mm balloon, showed improved saturations without any fall in cardiac output and systemic pressures. So this fenestration was closed using 8x6 mm LifeTech PDA device. This is 5 years child, status post right BDG for tricuspid atresia. Here actually this child post-Glenn had MAPCAs. So these MAPCAs was closed using Cook embolization coils. And after at 7 years of age, after Fontan, this child had to undergo fenestrated Fontan in view of high pressures. So later Fontan angiogram showed Fontan fenestration, and which was again occluded using balloon, and the result was increase in saturations without any reduction in blood pressure or cardiac output with stable hemodynamics. So the fenestration was closed using 12/10 mm LifeTech PDA device. So this patient has undergone both MAPCA closure before Fontan and fenestration closure after Fontan. So with this, I want to conclude that percutaneous interventions often provide a successful bailout option in various complicated situations in univentricular hearts with reasonable efficacy and safety.